Hello, everyone. I am Sharice Maynard, your moderator for this panel. I'm a healthcare strategist by trade. I've been doing this for 20 years. I help companies scale in the US and abroad, and I help foreign companies scale in the US. I love this talk. I also sit on the board for the SHARP Index, where we study physician burnout and we try to eliminate physician suicide. So we're going to get into this discussion, and you guys, we've got something special for you. If you ask a question, we're going to give you a copy of Micro Skills, written by Dr. Lewis, one of my favorite people on the whole planet, and Dr. Indira Landry. Here's the thing. We all have that person in our organization who insists on having meetings about everything that could really just be an email. You're going to win this book. You're going to take it back to them. You're going to say, I thought about you today. It will change both your lives. So let's get into some questions, okay? So my first question for this panel, because we want to define what we're here to do. We're talking about reclaiming joy in medicine. So I'm going to have each person introduce themselves, 2 minutes or less, and tell us from your framework or from your point of view, what is joy in medicine? You can start with Joanne.
Great. Oh, hi, I'm Ann Difede. I'm on the faculty at Weill Cornell, Department of Psychiatry. I'm a trauma specialist, and beginning about 20 years ago, I started to develop the use of immersive technology, in other words, VR, to treat trauma, stress, and pain in a variety of populations, World Trade Center, and now we're fast forward combat and fast forward again with healthcare workers. Let's see, that's the brief. And we work a lot with burnout and work during COVID setting up programs that were not tech-based for our physicians and frontline healthcare workers. How do you restore joy in medicine? Well, how much time do we have?
No, well, we're just defining it from your lens.
What does it mean? Satisfaction with one's work, feeling that maybe what you went into, whatever your specialty is, what you trained for, that you have peak moments where things flow together and go really well, and you can take that home and it's worth more than, anything else, perhaps. Getting your paycheck, but not really.
Risa?
She3? No?
There
we are. Okay. Before I introduce myself, I actually want to ask everybody to please give a round of applause for Megan and Andrea and Janae and Sharice, our moderator, for just doing such a great job and putting this together. It's I've been here before, and also actually another hand of applause. Sharice is like a moderator. She's a reader. She's a boss. And so, thank you for that introduction on the book. So my name is Risa Lewis. I'm an emergency medicine physician and a lifestyle medicine physician. For 25 years, I worked in the emergency department, and academically, point of care ultrasound was my niche. That and equity in the workplace. I started writing, move this a little bit away, maybe to stop feedback. I started writing academically medical and scientific journals like PubMed. And I increasingly, right before the epidemic, started writing in mainstream outlets like Harvard Business Review, Slate, Fast Company about the workplace. And what happens in healthcare is no different than industry.
Yeah.
1, 2, 3.
Sorry.
No worries. So when I started writing for the mainstream outlets, we weren't surprised that people really resonated with my co-author and I, what we wrote about the workplace, because what happens in healthcare is what happens in other industries. So what Reese referred to, this book, Micro Skills, came out a year ago, and it's a workplace playbook. It's a business book. It is written by doctors, by women, but it's not for doctors or just for women. And what I'll just highlight in terms of joy in medicine, chapter 1 is Micro Skills for self-care, because healthcare, just like other industries, does not teach us how to take care of ourselves. It doesn't model it. It doesn't laud it. And it doesn't reward it. And so I think part of joy in medicine for me has been really doubling down on self-care. And the more we know this, we take care of ourselves, the better equipped we are to take care of patients, of each other, team members, and ultimately a better work product results.
Brian?
All right. Well, good morning. Morning? Afternoon? I'm not sure what it is. Well, good morning, everyone. My name is Bryant. I'm on the faculty at Princeton, and I lead a healthcare transformation initiative there with a focus on innovation through the lens of policy, economics, and technology. I think joy in medicine, to answer your question, is getting providers back to the bedside, getting some of the burden that they've carried away from them, and enabling patients to be able to do well. I think if we can get our system back to that, then we can get to where we need to be.
Hi, I'm Lauren Deutsch from Lauren Academic Services, a licensed clinical social worker and educational therapist. Worked in medical education for about 30 years. Really thinking about a border of two disciplines where people get stuck in their learning and then need to get unstuck. That's basically the service that we provide. And we do a lot of coaching one-on-one, as well as small hybrid groups and workshops, et cetera, to both work with students, early career positions, and kind of across all specialties, and doing a lot of work around decision making. So how we decide both clinically as well as, say, on a board exam or licensing exam. So it's all of where a lot of our work is. In terms of joy, I think of it as something that's pretty idiosyncratic. I think it's really personal, deeply personal, actually, to the individual. So, I mean, imagine if all of us closed our eyes and sort of tried to picture what joy is. We'd probably all come up with different answers, some crossover. But I think what Bryant said, sure, absolutely makes sense. I also think it's about knowing, like, you want to get up in the morning and go do the thing you do. And I really do think that sometimes it's such a small statement, but it means quite a lot. I think at the end of the day, it's caring about what you do and really wanting to lean into it and not just give lip service to it or grab a paycheck at the end of the day. So there, that's what I think.
Well, thank you. Brian, I want to start with you because you've worked on both sides of the fence, and I'm a policy geek myself.
Sure.
I write policy as part of my profession. Where do you see the actual distress in medicine for physicians? What are you seeing?
Yeah, good question. So as you said, I'm at the policy school now at Princeton, but I'm a physician by background, and I think I look at this kind of burnout issue from two layers. I'm a big believer in someone, I think in the last panel mentioned looking at the problem from a systems lens. I try to describe it maybe on two levels, what we call the big S, or the big system, which encompasses kind of national policy, national economics, national trends and technology, and then little s, those same three parameters, but at the individual healthcare organization level, like a Brown or another entity. At the organization level, a lot of the drivers of burnout we're very familiar with, right? So it's documentation burden, it's not having the clinical support that most providers need. There was a great study that came out recently saying that more than half of physicians around the country do not have the administrative and clinical support staff that they're supposed to have. It's not having enough time with your patients so that you're spending more time on everything else and that taking you away from what used to bring you joy. But I think part of what I'm very interested in is understanding why, right? So when physicians talk about having to hit those productivity metrics year over year, you put all those pieces together and it leads to this disillusionment between why I went into this field and the realities of what I actually face. If we take a layer back, though, to the big S, I think you can find a lot of the larger drivers of that, right? There was also a great question earlier from a gentleman up here, Neil, who asked, well, with all this AI stuff, will this actually improve margins? Will this actually improve some of the outcomes, right? And I think at the national level, it is that same economic pressure, declining reimbursement rates, which we know has been a continuing trend for the last 20, 30 years and is not improving. It is this movement towards market consolidation, which, as we know, these smaller independent groups are getting gobbled up again and again and again. It is the policy decisions like making cuts to Medicaid while doubling the actual amount that was set aside to reimburse for or to fund Medicare Advantage on the other side. These kind of factors, as we put them together, create an environment in which individual health systems don't really have a choice. They have to increase the productivity metrics to offset the losses. They have to cut workforce to generate some kind of a return to keep the entity moving. And unless if we look at it from that global lens, we really won't be able to solve this problem at the individual health system level. And so hopefully we'll have a chance to unpack some of that today.
Wow. Risa, every day I'm inundated with these solutions, these AI adoption solutions. And you've worked in ED and the emergency department, forgive me, where we see rapid deployment of these. Now, ED tends to have thinner margins. Where do you see ED going with these solutions, and where are you seeing progress?
So it's a great question. Many of you won't be surprised to know that in terms of, there was a recent Medscape 10,000 physicians survey asking, are you burned out? And, huge percentages of physicians self-reported being burned out. Highest emergency medicine. Emergency medicine also has highest levels of death by suicide, addiction rates, et cetera. And so to tie in AI technology rollout, I think there's all these measures trying to be implemented to alleviate, mitigate burnout. And by training, I do a lot of healthcare design work, and human-centered design, healthcare design is having the end user at the table when you're trying to answer the question, develop the solution. And I think historically, medicine doesn't do that. It's very vertical, very hierarchical, and it's sort of this top-down, like, well, let's just do this. This will work, and kind of blame the patient. They don't take their medicine 4 times a day. Well, why? It's hard to take a medicine 4 times a day. That being said, I think when these solutions, technologies, AI are rolled out, I don't know a percentage, but I think often they're not designed with the patient at the table, with the physician at the table, with the caretaker at the table. So I'll just give a quick example of triage. So the provider/physician in triage has become a very common model in emergency medicine because crowding is just astronomical. People are leaving without being seen. Patients are dying in the emergency departments. There's boarding, so there's a sort of block to the flow upstairs when patients are admitted to the hospital. The waiting room times are really, really long. So there's a study, it was a research letter that was published in Annals of Emergency Medicine this year, 2025, and they looked at an AI triage model, looked at this sort of human way of triaging versus using AI modeling. And this is actually what I would deem something with more, it's more than a proof of concept, it's something very, very promising. When patients get triaged, and many of you have probably visited or had a family member visit an emergency department, you get an ESI, that's an emergency severity index. 1 or 2, you're sick. You may be even in cardiac arrest. 4 or 5, you've probably twisted your ankle and your vital signs are okay and you're deemed okay to stay. Humans doing that ESI assignment versus AI. AI helped actually more accurately assign an ESI and actually specifically brought back in marginalized in medicine groups that were getting under triaged. So there's a big positive role for AI, but I think the key is in the design and making sure we have the end user at the table from the beginning.
So we also need to talk about vocabulary around burnout, right? So Lauren, can you get into it with us the idea of burden versus burnout versus depression? What does that look like?
Yeah, I think years ago when I started doing what I do, it was asking a research question and getting funding. I was at the University of Chicago and working in the student counseling, seeing a preponderance of students and residents coming in, describing symptoms that sounded a lot like anxiety or a lot like depression. And I didn't really have a name for burnout at the time. It was in the later 90s. And I wasn't really thinking about it in that way. But I think when we look at burnout, what's interesting is that in the DSM, we don't have a proper diagnosis there. We look at it as a syndrome and a cluster of symptoms. And so it describes a lot of different kinds of behaviors. And again, I think it can be idiosyncratic or even institutionally located, but it largely what we're talking about is individuals who are contending with symptoms that are really almost preventing them from functioning in a way that they would normally function, and also preventing them from doing the work that they've been hired to do. And so longer and longer hours, the burden piece, I think when we think of like workload burden or we think of administrative burden, those are contributing factors. I think that's sort of on the way to burnout potentially. That's how I look at it. But when we think about whether or not that's something we're going to fix or address. I think Risa made a really important point. We have to have all of the stakeholders at the table, because someone's definition of what burnout is, or someone's definition of what's burdensome, we all have aspects of our jobs that are burdensome and where there are burdens. But when you're talking about pajama time, or you're talking about late into the night, trying to finish up, records and so forth, that's long exceeding what you're supposed to be doing. That really isn't then patient care, and it's not really even getting to sort of how do I then practice self-care, because there's no after-hour time to do any of that. So I think of the burdens as more of the contributing factors on the way to burnout. And I think DSM is going to look at, ultimately, I hope, from a system-based perspective, and look more from a human perspective at what these cluster of systems are. I think as a clinician myself, as a therapist, that's how I would, neurobiopsychosocial emotional, but thinking about that, diagnostically, I think would help legitimize that piece.
I may. I would add that there's a lot of overlap with moral injury and with PTSD. The rates of post-traumatic stress disorder in healthcare workers, particularly ED, ICU, frontlines workers, are actually very, very high, and they rival that of our combat veterans. And there's a tremendous amount of overlap between the phenomenology of burnout and the symptoms of PTSD. And I think that's important to recognize. And then there's moral injury, which I think contributes to burnout, where we don't feel like we don't have the resources, or we're forced to make decisions that are contrary to our values. During the pandemic, that of course would be perhaps an ED doctor who's trained to save lives, and you don't have even adequate PPE to go in and take care of a patient. And so I think there's some more nuance there. And where I'm going with this, though, is that, as Lauren said, the burnout is not in the DSM, so it gets ignored as a condition, if you will, that's associated with suffering, functional impairment, loss of days at work, absenteeism, presenteeism, and disability. And where I'm going with this doesn't get treated, if you will. Right. And it's only if it's really recognized as anxiety, depression, or PTSD. And unfortunately, PTSD is very hard to diagnose in a cross section. So, that's.
Well, let's talk about some of that, Joanne. Your solution, your VR solutions, you've had the opportunity to actually put some of these things to test. Where have you seen wins in this area to identify burnout and actually mitigate some of it?
Well, so we don't use VR at the moment for burnout. We use it for the treatment of PTSD. However, we are, with the advances in technology now, where you can actually, very quickly create an avatar of yourself and integrate it into a virtual world, we are going to start looking at moral injury. And maybe we should be looking at burnout as well. So that if you see yourself from a third-person perspective, the idea is that it might be facilitate your processing of whatever event, or really multiple events, that led to you feeling injured morally. In terms of trauma, do you want me to answer that one too? In terms of PTSD, the way when you develop post-traumatic stress disorder, your brain kind of narrows down the stimuli process. You can become numb and avoidant. And so one of the things we think this sort of intervention does is it kind of bypasses our willful, conscious avoidance, and immerses us in a multi-sensory environment to allow the processing of the trauma memory. And so we think it contributes to success in treatment because it requires less effort in a way. Everything is people prefer it, and there's a lot of data across all kinds of psychological treatments. If you prefer the treatment, you're more motivated to do it, you're more likely to stay in it. I'm sure that's true for compliance for other areas of medicine as well. And then finally, one of our most recent Department of Defense funded multi-center trial of combat-related PTSD, which is a translational model, but leaving the genetics and everything else aside, we actually found that if you had a comorbid depression, which half of people with PTSD do, you are more likely to do well in the virtual reality form of behavioral exposure therapy than in the imaginal exposure therapy, which may contribute, which kind of gets to my point of, it activates you and doesn't really require as much effort. That's what sort of what we're thinking now. And we're now applying all that this to healthcare workers.
Okay. Risa, you from the ED department and different clinical settings, how does burnout manifest itself?
So I think it manifests similarly in many, many environments. So it's some of the symptoms that have already been mentioned and described. I think when you wake up in the morning, you're not looking forward to your day. You look at the calendar and you dread everything. This sort of sense of, just getting through things as opposed to looking forward to and enjoying. People have made the clear distinction of burnout versus depression. They often come together, but they are distinct entities that I won't define here. I think I have colleagues that are better at defining, but I think there is a Venn diagram overlap of burnout, depression, PTSD, and moral injury. And I really want to dovetail off this discussion of moral injury. Actually, Health Impact has had Dr. Wendy Dean, who wrote a book about moral injury here. And I think now that this concept of moral injury gets placed on the radar, I really, really embrace that and think that that is happening a lot more in the workplace. When people are saying burnout, I think it's more moral injury. So what I'll say in the emergency department is with limited resources, limited PPE, not being able to give Tylenol when someone has a fever, or, making decisions about who is sicker, and, even this ESI score that I just referenced with triaging patients with long wait times, bad outcomes, as I mentioned in the waiting room. All of these things end up weighing, and it is this feeling that you're not given the resources, you're not equipped, you're not able to deliver the patient-centered care that you're taught to deliver. So it's not so different, but maybe more intense in certain environments like the emergency department.
Mm-hmm. I think too, another place where I think it's like the stress response, but really the chronic component to that. And so at a point, an intersection of where you have to make decisions, both clinical decisions and other, you're all of a sudden pulled way off of that. And so I think times get, there's a more elongated process, or maybe an avoidant component, there may be a perfectionistic component, there may be I can't do all of this, and so I'm giving up or giving into it. And I think that piece over time, you're not talking about a couple of days, but you're talking about over months and years, right? And that, I think, becomes another layer to this. And that's across any of the specialties, really. We've certainly seen it at LAS. It shows up time and time again, certainly in ED, but really across every one of the specialties. And that part, I think, when that goes on for too long, your ability to make a decision under those situations is far more compromised, as we would expect. So efficacy and accuracy, and I think when we think about how to address that needs to go into it too. Sure.
Bryant.
Yes.
This is a business specific question. I want to shift focuses just a little bit because I always say the why informs the buy. If you want somebody to buy into these technologies we're speaking of here today, you have to build business cases for them. How do we do that with leaders?
Yeah, good question. So I think one of the things that is crucial, and it's so fascinating to hear these conversations from these experts around these core elements of burnout and distress. I think from like the health system management perspective, though, one of the keys is always the ROI and the business case behind this. I think there was really an era early on in which approaching wellness was all through altruism, right? We have to do this, we should do this. But as your margins become increasingly thin, whether that's implementing AI, improving your EHR, or in improving patient access, you have to take into account the economic toll that has on your system overall. And so I think one of the core things to do that from a well-being perspective is to redefine wellness as an operations issue. Anything that impacts the workforce, the ability to deliver care to patients, anything that threatens patient safety and quality, at its core is an operations issue, as we, I think, saw very clearly during the pandemic when that was the case. And so in order to do that, we have to shift to this, what I call the no more yoga approach, which means that we're no longer going to look at this as ice cream socials. We're going to sing Kumbaya on the rooftop at 6 p.m. and then do a yoga retreat, and instead begin to recognize that all of the problems that these leaders have specified come from core flaws in the system itself. That's what's leading to the distress. That's what's leading to the moral injury and all of these things. And so I think we have inadequate tools, to be frank, to actually help leaders do that. We have a system that we've built at Princeton that attaches an actual economic value to the work that providers do and to some of the challenges. So to give a quick example, maybe to borrow from Risa's domain, if as a provider, when I'm seeing patients in the emergency department, if my equipment is not where it's supposed to be, if I need to go to the other side of the ED to get a laryngoscope or otoscope or whatever that might be, there's a certain amount of time that is attached to the time that she needs to go and find that and see the patient. That is tied to an economic number. All right. There is an indirect cost that system leaders are not seeing as a result of that. Our tool is able to calculate that and provide those numbers, taking into account turnover, reductions in effort, you name it, other burnout factors. And when system leaders are able to actually see how well-being and burnout impacts the bottom line and how improving that number can help, 7-8 million a year losses because of these inefficiencies, they are much more inclined to solve those problems, improve those kind of clinical gaps, and more importantly, to actually make the upfront investment that's necessary to make the workflow what providers need to prevent burnout.
So you have a working model right now that
We do.
Oh, wow. Okay.
We do.
Joanne, speaking of working models, can you share a use case or a case that's been successful in your work?
Well, to extend what you were just saying, if I may, and before I'll get to the design space, but actually it was really I'm spot on. I'm really glad to hear you operationalize it that way, because dating all the way back to the World Trade Center attacks, we had a contract. We've written many papers about it with our utility company to assess all of their workers. Turns out like 13% had trauma, and they hired us to treat their employees. Where I'm going with this is the way I sold the budget was to point out to them, as I've also done with our own healthcare system for increasing the budget for our EAP, was to point out that the cost of one physician disability or one nurse disability from, say middle age on actually was greater than the cost of the budget they wanted to give us. So it actually got us more money for both of these programs over many, many years. So that's a kind of a use case, but not the one I think you wanted me to talk about, right? You want me to talk about user design or, yeah. Okay. So in developing the latest environments for healthcare workers, we have always used from the very beginning, even with the World Trade Center early work when it was experimental, an iterative process where either we interviewed people clinically, or we bring in the end users. So we brought in critical care docs, and these were people, our collaborators and colleagues, brought in nurses, brought in respiratory techs to develop the COVID environments, along with non-clinical staff like our transport workers and our environment EPA workers, because they were all affected as well too, right? They were all right there in the environment. And so, we learned specific things like, perhaps the rhythm of the respirator didn't sound quite right. Or the placement of an exit sign, things that were related to safety. But most importantly, what we learned in all of our work with end users is that we all have great imaginations, and so you need to leave a lot of room. There needs to be realism, but you need to leave a lot of room for a person's imagination and memories. And the only mistake you can really make in designing these environments is adding something that doesn't belong there, that's distracting. Maybe not the only mistake, but one of the major ones is like pulling someone out of the immersive environment by, say, for example, in another world we developed, the ambulance sound we used for something we were doing in Western Europe was that of an American ambulance, and so the EMTs were like, this doesn't doesn't cut it, so we had to change it, because as it turns out, sound is very important to facilitating immersion. That's a short. I can go on, but we don't have very much time, so.
That was a great answer, actually. Risa, let's look at, you and I have had conversations about some of the buzzwords we hear, like human-centered, end user-centered. What should be the key indicators to say that, okay, the end user or the person who's experiencing this tool is actually experiencing it in a way that's improving?
Mean once the solution has been rolled out or the device, et cetera. Well, I think, this is actually interesting because say you do a human-centered design project, like a device, I think once it is rolled out, once it is deployed, once it is out on the market, there isn't often that post evaluation. And I did some work with an architecture firm on the built environment, like building hospitals, and they talked about that there's always supposed to be this post evaluation 1 year out, 5 years out, but that costs money. And so there's often not that investment in the post deployment evaluation and analysis. And I think part of it is it takes so long for something to go live. If we use the example of a hospital, innovations that are known to be scientifically valid take 15 years to really go live in a hospital system. Like medicine, healthcare is quite slow. It doesn't move as fast as, Silicon Valley. And so to answer your question, it's expensive. We do need to bring people back in to ask, maybe not literally, but figuratively. We need to ask and get feedback and realize that environments change. And the one example that comes to mind is like the workplace. The workplace is no longer like necessarily a built environment. The workplace is virtual for some people, and it's sort of mixed for many businesses now, where you're both in person versus from home.
So that there's modifications that can be made in real time. And then also, what are we doing to measure it, which would require a shared understanding of the problem or definition of the vocabulary. I think it's also about then what are we using? Is it self-reporting? Are there inventories? Is there some, in addition to looking financially at what are the cost savings and so forth? I think that's another layer within it. Yeah.
So this is to all of you then, and I'll start with you, Lauren. Are we doing more harm than good with these extra layers of technology and innovation that one thing we see a lot of is, oh, this solution is going to unburden physicians or take over documentation, and then the physicians are unhappy. So are we asking the right questions to get the innovative solutions to doctors?
I'm going to be evasive and say I think it's a complex question, and it doesn't have probably a yes/no answer, because I think it depends on what we're asking or what we're looking at. If there is really AI, or if there's really some ambient AI or I guess ambient AI in this case, to do some of the SOAP notes, or to make sure that we're getting all of our EHRs completed and so forth, that can be wonderful and helpful. If it's taking away from the actual provision of healthcare that the provider would be doing otherwise, I'm not referring to what Santara was talking about per se. I'm talking more about like the actual meeting somebody and doing an H&P and really thinking about, what's happening right there in that moment, being able to listen. That piece, my concern is that if we're taking away from that too much, that also maybe obfuscates the reason why so many of us went into healthcare to begin with. I mean, part of why we entered healthcare is because we want to help and we want to provide healthcare care, which actually does require interfacing with human beings. In fact, about joy in medicine, that gives me a lot of joy, right? I like that. I actually love that. So if that wasn't available to do now, if there's no nurses available, no physicians available, and we're talking about providing, a stopgap for that, or providing a solution to that, I understand the distinction. So I think it's a complex question. I don't think there's a sort of dichotomous answer there. So I think that's sort of how I would respond. I think it's dependent upon what we're looking at and how we're defining a burden or burdens versus what we're looking at as burnout or emotional compassion fatigue faculty. I mean, this is where a lot of this started in PTSD, as you're describing. So,
Right.
Yeah, I'm going to take maybe a little bit of a different stance from Lauren. I think this is an exciting time. And actually, Teresa's point, I think the healthcare landscape has changed. We are in this hybrid environment in which what was traditional care at one point and what we considered care, which took place within the four walls of the hospital, I think is very different now. As far as the use of AI in tech, I was actually in Silicon Valley yesterday and had a chance to meet with a few startups and VCs that are working in this space. I think the exciting part is there is innovation that is happening now that can and will revolutionize how we approach care. Some of that's very high tech, very AI based. Some of it's very simple and it's just redesigned. There's a company called Summer Health, which I think actually presented here not long ago. It works with parents and those that need access to pediatricians. It's a simple kind of like monthly subscription fee. Parents just text with the pediatrician and you're guaranteed to get a response within like 10 minutes. It's for when parents don't want to have to go in to a visit or have to get on a virtual visit. They just want to have that access to a pediatrician. The docs I met with that work for the company love it. They have flexibility in their schedule. They're actually able to manage and take care of way more patients. And it's actually a low tech innovation that I think could have a really big difference. On the other end, I met a company that builds avatars for physicians using this interactive capability with patients that uses generative AI that actually solves for the hallucination problem. So it puts a hard stop on the answers and all the content is pre-approved by the provider. But they actually create a digital dub of your voice and actual face to where when the patient is discharged and they go home, they are interacting with their physician. The beauty of this is they're able to ask questions like, well, wait a second, how should I take a shower after this operation? How should I handle X, Y, and Z? All the stuff that you have to think through when you're sending a patient home. But the beauty is it also has question prompts that they may not have thought to ask. And so instead of getting a discharge summary and notes or having a nurse educator try to run through things when a patient is still maybe a little bit kind of out of it post-procedure or prior to discharge, this tool really enables them to engage. And so I think there are resources. And as a physician, I will tell you, knowing that you have that and where patients ask questions in their system that have not, that go kind of beyond what the physician has approved, you get a notification immediately that says, this patient, 8 of these patients are actually asking these questions. We need to add content in this area. And so it prevents the hallucination of making up an answer, and it allows that database to improve over time. I think when we look at these kind of low and high tech solutions, I really do think that innovation holds the potential to change a lot. Philosophically, I think entrepreneurship is one of the bedrocks of this country and of healthcare in our field. I think the real challenge, though, lies not with the ideas and the innovation ecosystem that we have here, but with our policy environment. So we can solve, I think, a lot of the problems that we currently have. The challenge is that we still exist in a policy environment that constrains what we can and can't do, right? We still are kind of limited to our traditional EHR because for most organizations, that's how you bill, right? Even if you have a cloud-based ambient system that could really redesign all of it, we are limited by kind of the four walls of what our national policy is. That's why I say we need systems change at both levels in order for it to be effective.
Yeah, definitely. Policy and innovation rarely marry each other.
That's right.
I remain exquisitely optimistic. I think that we have to continue with innovation by its very nature is going to progress the workplace. And AI, not everything's going to go well. Not everything's going to help. But I think the people behind these innovations have that goal. And I will share that I'm a faculty advisor for a group of master's students up in Boston, and they created this device, this AI app called Lexi, and it is for patients with limited English proficiency, so people that come in and need language translation services. And it is immediate translation based on the language. And it's both a wearable as well as something on the computer, as well as something that will be able to listen. And, you know, as someone who has had to wait for a translator, or I have been the recipient of a story of a friend who is deaf and uses sign language, and the screen that was being used when she had a healthcare visit cut off like from her wrists down, so the full sign was not interpreted correctly, so they weren't able to understand her healthcare emergency, and she was sort of triaged as less emergent than she truly was. And so I actually think something like that can really, really change, getting the right chief complaint diagnosis and acuity level. So I do think we have to be optimistic. I think we are optimistic. Otherwise, this room wouldn't have people such as we are in the room in terms of innovation, entrepreneurship. And I think, yes, physicians can be entrepreneurs, and yes, entrepreneurs can play a role not only in the design, but also in the patient care. We need everybody at the table.
Joanne?
I think the other panelists have been so thorough and time is short that I'm happy to just pass and say I agree with everything that's been said.
Okay, do we have any questions? Young man, how are you?
Good. I guess I could project. It's fine. Licensed social worker in the state of New Jersey. I came into healthcare with a mental health focus. Really appreciate the discussion. When it comes to sparking, enhancing, reinvigorating joy and purpose, right? Really focusing on those core tenets there within the individual. Where should our initial focus land? Should it be internal with that perspective and narrative that the person is kind of sharing and internalizing, or should it be on some of those external environmental factors and some of those other characteristics of what's going on around us in the environment?
As an LCSW, I'll answer from that perspective. I mean, I think it's both, really. I think a system-based perspective really requires something that's integrative. So I think you do need the external piece and the front-facing. I think also internally at the institutional level, and certainly from a design perspective, because that's going to have institutional relevance for that place at that time versus, for all regional in the area or nationally. So, I mean, that would be one element for sure. I be curious to hear about others' perspective.
I agree with everything you're saying.
We had another.
I'll add to that. I think, first of all, good to see you again. I think there has been so much work done over the past 2 decades on improving personal resilience among providers, especially among physicians and whatnot. I think there's a treasure trove of resources there. What we're lacking is a better system. And so I would say the focus needs to start on building a better external environment. That includes the built environment. That certainly includes the policy and economic environment, so that providers and especially young trainees that are coming out are entering a field in which they can have that connection to purpose and joy and all the things that you mentioned. We know, one thing I think we can all agree on is the current system isn't working. Last thing I'll add is I think with all the focus on the personal individual resiliency piece, our colleague Colin West from Mayo published a piece years ago that found that if you look at least physicians on a spectrum of the U.S. adult working population, their resiliency scores are way above, standard deviations above the norm, right? And so this focus on making the individual better, I think, is a flawed perspective. It's part of what's led to where we are. If we can build a better system, potentially with some of these innovations we've talked about, I think we can hopefully move healthcare forward.
And I think there was one more, John. This is our final question.
This may be a little tangential to the topic of joy, but Bryant mentioned the policy restrictions around current environment and what's happening with our EMRs. What do you see beyond the EMR as a solution?
Yeah, is that for me? Oh, okay. Yeah, so I think that's a great question. So beyond the EMR, I think what it really comes down to are a couple things, and maybe for the sake of time, we won't go into all of it. Some of CMS and HHS's reimbursement kind of strategies and plans, to me, I think are actually hurting the healthcare environment. I mentioned one, Medicare Advantage, we know is a controversial topic, but one in which if we are, again, doubling the amount that we're reimbursing and paying there while simultaneously cutting Medicaid. I mentioned indirect cuts earlier. Cuts to Medicaid do not actually net save the government money. Those costs just get passed on to private health systems, which hurt us more. The other thing I think, though, is we need more of an innovation focus at the congressional and kind of policy level. And right now, I think we kind of swing between two extremes. So in January, the Health Technology Act of 2025 was proposed before Congress. If you haven't heard of it, it is a bill that seeks to grant autonomy to independently practicing AI algorithms to prescribe medications without supervision. That is an actual bill before Congress right now. It hasn't gone to committee yet, but that is an actual bill. I think that's one extreme. On the other, you have kind of the Luddite approach, which is we're going to restrict completely, limit all access to AI, make sure that we have a very tight fist over what's happening. There has to be some kind of a middle ground where the best and brightest ideas that are coming out have a place to thrive. And I think that's the only way we'll be able to move that forward.
Thank you, guys. This has been wonderful.
All right.